Hello, everyone. Welcome to another webinar from the Steps Forward Innovation Academy. Today's topic is Transparency in Action, the Mental Health Parity Index. And over the next 45 minutes, we will explore the Mental Health Parity Index, a revolutionary open access tool that analyzes commercial insurance plans to compare mental health and substance use coverage and payment with physical health services, using transparency and coverage data plans are required to publish publicly. Please note that this webinar is for informational purposes only and is believed to be current and accurate at the time of posting. Please consult a professional advisor for specific medical, legal, financial, or other advice, and references and links to third parties do not constitute endorsement or warranty by the AMA. Let's just take a moment to go over your experience today as an attendee. If you're joining us on Zoom, you will see a dark menu bar either at the top or bottom of your window. There you can access a selection of resources related to this webinar, including today's slides. There's also a link to stepsforward.org where you will find all of our past toolkits, podcasts, and webinars. If you don't see these options, select the three-dot More button to access the resources and the Q&A. If you're joining us on YouTube or LinkedIn, welcome. You can follow the link in the description to join us here on Zoom, access the resources, and ask questions for our speakers to answer. After our webinar concludes today, you will be able to claim 0.75 continuing medical education credit hours. You can follow the link in the resources tab to the AMA Ed Hub and claim the credit there. We'll remind you of all of this at the end, but for now, we would like to introduce you to today's learning objectives and speakers. I'll pass the floor over to Chris.
Thanks so much, Alec. Hi, everyone. Thank you so much for joining us today. I'm Chris Botts from the AMA, and I'm glad you're here for this important conversation about strengthening behavioral health access. Today, we're digging into something that affects patients, clinicians, and communities every day, and that's timely access to mental health and substance use care. Today, we'll briefly talk about what mental health parity and transparency laws are meant to do, why existing efforts continue to make it hard for people to get behavioral health services they need when they need them. And a big focus of our session is on the new Mental Health Parity Index, an open access tool that uses transparency and coverage data for commercial insurers. It gives us, for the very first time, a clear way to compare mental health and substance use disorder coverage and payment with physical health coverage across plans. Our discussion will highlight how this data can help uncover coverage gaps, guide policy decisions, and support evidence-based advocacy across states, so all of us have better information to push for true parity. And as we walk through the index, we'll also talk about what comes next, how physicians, other clinicians, advocates, and policymakers can work together to boost transparency, strengthen oversight, and improve enforcement of federal and state parity laws already on the books. And of course, we'll leave plenty of time for questions, so feel free to drop those at any point in time. So let's jump in. I'm joined today by Nathaniel Counts, Chief Policy Officer at the Kennedy Forum, and Daniel Blaney-Cohen, Senior Attorney at the Advocacy Resource Center here at the AMA. Thank you both for joining us today. Next slide. So just briefly, wanted to, for those folks that may not be familiar, have a brief overview of what mental health parity is. In 2008, a law was put on the books that requires commercial health plans to provide benefits covering both mental health and substance use disorder treatment on par with medical surgical services. And yet, in almost the 20 years since that law has been into effect, both state and federal regulators have continued to find evidence of widespread failures by health plans to comply with these laws. That has created general opacity of prices and networks. That's created erratic distortions with rates and access to services. It also means that individuals are still far more likely to access mental health and substance use disorder services out of network compared to med-surg services. And ultimately, those out-of-network benefits lead to more patients having cost sharing, which means that they are substantially reduced, have reduced access to utilizing and accessing these life-saving and cost-reducing services. Next slide. So given that frustration and work that's been going on for almost 2 decades, the AMA partnered with the Kennedy Forum and Third Horizon to launch what we call the Mental Health Parity Index, in May of 2025 in a pilot in the state of Illinois, which built on appropriations specified to the Kennedy Forum via the Illinois General Assembly. And this free open access online tool focuses on measuring commercial insurance products on both their payment and access to mental health and substance use disorder services and compared to med-surg services. The critical part of this and why this is such a timely effort is that this work leverages fairly new machine-readable file or MRF files, which were made publicly in 2022 based on the transparency rules, which compare insurers' payment as well as access. Next slide, Nathaniel will give a little bit of overview of the initial results that we found in the pilot, and then we'll continue the conversation from there. Nathaniel.
Thanks so much, Chris. So these are sort of the high-level findings of the tool, and in a second we'll get into the details of the tool. But some of the main findings are, and we'll get into like exactly what this means, but the percentage of in-network providers was higher than physical health by, it's like 38% versus 27%, which is a 34% difference in between sort of the in-network providers on physical health side and then in-network providers on the mental health side. Another big point is that, and we'll get into this much more detail in a second, that physical health outpatient services were paid more than mental health and substance use services, normalized in the way that Chris mentioned, and we'll just kind of show you what that means in a second. And so it was like a 26% difference between how those services were paid. And then we found that inpatient physical health services were paid much more than inpatient mental health services. And it's sort of an interesting point that we'll get into in a second. If you look at the DRG, which is the standard payment rates, they're about same for the hospital, but what it doesn't account for is the fact that mental health and substance use visits tend to be longer than physical health. Like the way that they were originally calculated looked at a different length of stay. And so when you look at the actual payment per length of stay, it's quite a bit more for physical health than mental health. So I just want, like, an important note at the bottom is that Illinois is also a leader in parity. So this is an interesting finding given that fact. And so now let me really get into the tool. So what you'll see here is a beautiful map of Illinois. And we have the 3 indexes which show each of the 3 ideas that I mentioned. And so we'll start with network composition. And so what this is showing specifically, and I'll highlight a county to really, so here's Chicago, to really make this vivid. So what it counts is, you'll see on the left-hand side the number of licensed physical health providers, and we did that by NPI registered in each state, so National Provider Identification Number. And so that's sort of a way to see how many people are registered as either physical health and mental health provider in that area with CMS. And we did, like, there's a whole system that we divided out the physical health providers from the mental health providers, and I'll get into the methodology details in a second. And so then you can calculate out, based on the transparency files, what percentage of the providers are physical health providers are in network versus mental health providers are in network with each plan. And you'll see sort of on the right-hand side that it's actually plan by plan, because each plan needs to release this data under the transparency laws. So it's sort of a very detailed view of how this is working. And then from that, you can calculate the percent difference between the number of in-network physical health providers out of the total versus substance use providers. And it varies quite a bit between counties and plans. So you'll see we have a 6.4% difference here, but let's look at Coles County, where you see like a 94.3% difference. And there's quite a lot of variation, which partly is explained probably by some of the contracting between providers, and then also the density of providers in that area as well. And just to kind of click through, you'll see there's 8 plans that we went through across this. And so you can see here's the physical health percent and the mental health percent, and we can even do that by county. So it's quite a powerful and interesting tool. But let's go now to the outpatient professional reimbursement index. And so what this looks at is, and let's click on a place. So what this looks at is we have the so it's like on a normalized basis. So we took out some kinds of physical health providers that especially might not be at all analogous to mental health and substance use providers, like surgical providers, and then looked at, based on the payment rates for each code, because the transparency and coverage files are incredibly detailed. It's like, and we'll go through this a little bit in a second, like every single service that they could be paid for. And sometimes it's like every service in existence, they just put it all in. And so what we do is look at the payment rate normalized by the RVU, which creates an apples to apples comparison across every service. So it doesn't matter what the specific service is, because the RVU unit makes it comparable across even incredibly different service types. So it's a different process than just looking at finding like mental health therapy codes on one side and occupational therapy codes on the other, or physical therapy codes. And then it does a comparison based on that. And then one other thing to think about as we did this is then we bounced it off claims data to weight it based on which code people are actually billing. Because one thing that was a challenge is, because every code is in there, you end up with like a dentist has a code for a C-section. And so to make sure that it's like actually the codes that people are using and like weight it based on that, we took national claims into account, because you don't have disaggregated claims data by plan and provider. And so this looks at the normalized amounts. And so you see like there's 49 or $49.9 per RVU. So that's the unit you're seeing for physical health versus 36.1 for mental health and substance use. And again, you can see by plan in the county, and you'll see like sort of variation. And there's interestingly much less variation across counties than there was in the network composition index. And so this is quite a powerful tool to look at reimbursement rates that was not previously really available before the transparency and coverage data. And this, the last one, which we mentioned, is this looks at, they're very similar because hospitals sort of negotiate across every condition on this DRG basis. But if you actually take into account how long people are staying for these payments, which were determined based on a older concept of how long people are staying, you start to see disparities there. And so, and again, the challenge we face here is this is only mental health units inside of larger hospitals, because the contracting for standalone mental health and substance use facilities is so different. They use like all sorts of different ways of calculating that across plans, so it's difficult to fully account for that. And just one last detail. So here's this, and it pops up as soon as you open it. There's so guidance about how to use the index. Again, the key findings you just saw. Really, the magic, though, is in this methodology and limitations. If you're brave enough to go in here, you're going to find extremely detailed formulas about how all this is working. And then if you're curious, like, well, how did you decide which services to include and how you think about it across types, which providers did you put in each type? Man, you can really get into it. And a lot of this was decided both, through the main partnership of the Kennedy Forum, AMA, and Third Horizon, but we also had this expert panel which brought in leading, parity experts from consumer groups, from sort of legal practice, from academic spheres and provider groups. So we had a broad sort of selection of people who are really leaders in this space, developing a joint methodology. And so with that, I will stop my screen share and we can get back into it.
Excellent. Well, thank you, Daniel. Hopefully folks start to see why we're just so excited for this work, seeing the impact of taking this just like tons of different data and putting a defensible methodology behind it and really trying to translate that into action. But Daniel, I want to bring you into this conversation and really help try to ground everybody to really understand what constitutes a mental health parity violation. We saw a lot of yellow, red on those maps, but what really constitutes a violation, or what are some of the ways that these violations show up in both coverage and care delivery?
Yeah, thanks, Chris, and that was great, Nathaniel. And I really want to emphasize the fact that this tool is creating apples to apples comparisons, and that's really important because at its core, parity, and I suspect most of the people who chose to attend have a working knowledge of mental health and substance use disorder parity. It's a law that's more than 15 years old, Chris, and so it's not new. It's not new to advocates. It's not new to payers. And the concept is very simple, that if a health plan provides benefits for substance use and mental health, those need to be comparable in both the policy and the application of that policy to the benefits provided for medical and surgical services. So it has to be comparable. That doesn't necessarily mean equal. It means comparable. And that those benefits should be able to be accessed in a manner that is no more restrictive than for medical and surgical services. So if you're paying for these benefits for mental health and substance use disorder care, you should be able to access them in a way that, again, is comparable. That's the most simple concept. And remember, so that's the idea, right? Unfortunately, and you alluded to this in your opening, for more than 15 years, payers have had extreme difficulty in complying with the law, which means, and this is also really important, every time that somebody tries to seek mental health services or care for a substance use disorder, and they don't get it, that results in patient harm. It doesn't necessarily mean that every time they aren't able to access services in a timely manner, there's a parity violation, but we have to look at what has traditionally happened. So what are parity violations? And this is what the federal government for ERISA plans governed by ERISA have found, and this is what state regulators, when they have found violations, have found in terms of violations. What are violations? When things like prior authorization or pre-certification for services are more restrictive for individuals with a mental illness or substance use disorder, then those services are for patients requiring medical or surgical services. That's a violation. When there is exclusion of therapy for treatments for autism spectrum disorder compared to treatments for medical and surgical services, that is a violation. When there is exclusion of access to medications for opioid use disorder compared to comparable medications for physical health services, those are violations. Increased restrictions on billing for physicians and other healthcare professionals who provide mental health care services compared to restrictions on billing for physical health services, violations. Nutritional counseling have found to be more restrictive for mental health conditions, exclusion of residential care or hospitalization for mental health and substance use disorder conditions compared to medical surgical services, exclusion or more restrictive services for telehealth virtual visits, and the list goes on. And also network adequacy standards. This tool is obviously, as Nathaniel pointed out, extremely powerful for that. These are violations that have been found year after year after year. And so while this tool doesn't say a violation occurs when somebody's in the yellow, orange, or red, what we're finding, these are opportunities for both payers and state regulators to identify there's a problem here. This problem might rise to the level of a parity violation because the policies that are causing these disparities in care are, in fact, more restrictive and thus indicate a potential parity violation. But they certainly require more investigation. And that ultimately is the power of this tool, to bring the right people together to go ahead and say, okay, here's the problem. Let's get at what the solutions are. It may be the need for parity enforcement. It may be the need for payers to take action on their own volition, which would be fantastic. So those are some of the things that we think are the real power behind this tool.
Fantastic, Daniel. Thanks so much. Nathaniel, to you, You touched about it a little bit when you were going through the demo, but is there any additional information you want to provide about how specifically the index leverages that transparent coverage data to reveal the differences between behavioral health and physical health coverages?
So I think the good thing to know is exactly what the transparency and coverage data is. And so what it is the negotiated rate between the health insurance plan and a provider for every single provider, for every single service, for every single product offered by each plan. And I think the total size of this data is a petabyte. And it's fascinating. I mean, I'm so appreciative for the work of Third Horizons in the data engineering and analytics. In my last job at the New York City Health Department, we tried to download even one major national plan's file, and it immediately crashed the computer. Then we tried with a minor regional plan, and we were able to download the data. And then we started an analysis, and we were invited to discontinue it immediately because it was crashing the servers. And so the size of the opportunity is just immense for both this, but also other applications. I think one of the most interesting things, and we'll get into this later, is that you couldn't do this before without having an antitrust violation. There was no way to sort of communicate about prices or anything across providers or across plans without sort of public intervention, without violating antitrust, which I think opens up a lot of opportunities as well.
Fantastic. Daniel, to you, why is this treasure trove of data so important to clinicians, professional organizations like the AMA, and how will this be important as all our efforts to advocate for the changes that we're striving to see?
Yeah, I want to build again on, thanks, Chris. I want to build again on what Nathaniel is referencing here, that this is the first time that people can see it. A picture's worth 1,000 words, right? And so in each of these counties, they don't directly line up with legislative districts, but there are legislative districts in all of the counties. And so it's important to remember when an individual isn't able to access care, and let's say it's in a crisis situation. And in that crisis situation, somebody has an opioid use disorder, and they're ready to seek treatment, and they can't find somebody in network who's taking new appointments. They've paid for access by virtue of their premium dollar to go ahead and have access to services. But if they can't find somebody who's in their network, that opportunity to start treatment might be lost. For somebody who has a mental health condition and they can't access the recommended services that are from their child psychiatrist or their psychologist or their psychiatrist, and they can't access those services because they're denied, or prior authorization means it's going to be delayed and then denied, the first thing that they're doing isn't thinking, well, I should really check out the where I can file a complaint to my Department of Insurance, because this might be a parity violation. No, I mean, they're understandably thinking, I need my family member, my loved one, my son, my daughter, my husband, my spouse. They need care, and hopefully it's not a crisis situation, but often it is. And so in those instances, we want to avoid those situations, right? And so this is an opportunity for payers using their own data to say, okay, we have some problems here, and we have to investigate why. It's an opportunity for legislators and regulators to say, all right, if this is the area of our state that has the biggest disparity in coverage. And one thing that the map doesn't show, it doesn't show mountains, for example. And so in other states, there might be a big mountain range, and so the distance driving and some of the other requirements under state insurance laws might not really apply. And so this is an opportunity using that apples to apples data to say, all right, if we know that the contracted rates for mental health professionals, for child psychiatrists, for example, are 50% lower than for medical surgical services. Of course, there's going to be differences in network adequacy. We don't want that to rise to the level of a parity violation. We're hoping that payers can do this more prospectively and use their own data. They can do it now, but they don't. But we're hoping that they can use their own data and identify these problems ahead of time, to go ahead and implement solutions. So those acute situations of not being able to find access to care or not being able to access the services recommended by their physician don't occur.
Fantastic. And I want to just note for folks, we have a lot of great questions coming in, but just as a reminder for folks to go ahead and submit questions. We'll go ahead and try to get to as many of them as we can in the limited time we have. We know this is a lot of information that everybody's processing, so we'll do our best in the limited time we have. Nathaniel, one thing I wanted to circle back with to you is, when you think about that data, it's really has a lot of opportunity, but there are some limitations with that data. Do you want to just talk a little bit about just some of those limitations and how the index tries to just adjust for that or address them to ensure we're just being cognizant that there's not a perfect data set?
And I think one of the big challenges we have is on its own, the transparency and coverage files can give you a lot, but it doesn't give you everything. So for example, without claims data, to Daniel's earlier point about like prior authorization and everything, we don't know, to the extent, like, even though it's in a contract, is it being billed? And if it's being billed, is it getting paid? Or like, what the utilization management is on it? The extent to which providers are seeing patients in that, like actually with that health insurance plan in that panel. So I think those are like one set of challenges. And then the other, just like an example of another issue, is that we arrange the network composition index in one way based on the available data we have, but we don't have rich data that allows sort of alignment with the way that state regulators tend to do network composition oversight. Because a lot of it focuses on time and distance to providers seeing new patients. That's sort of like the basis often of network composition analyses. But for example, we don't know where members are located. So you can't really do time and distance, which like especially matters in a large county. Like we could try to do probabilistic sampling of just assigning people to places in MSAs within counties. But it's not that strong, and without claims data, we don't know who's actually seeing new patients, or just like based on provider network directories. So there are some issues, and then just the issues around who would be seeing, like who would join networks if there was parity and reimbursement. Just challenges around fully scoping out some of these issues. But it remains, good data to work together in the ways that Daniel outlined, and a powerful start.
Yeah, and it changes the conversation, right? Something we couldn't do before. It really allows to have kind of that dialogue of identifying, Daniel, to your point, some of those issues and how do we resolve them versus kind of the throwing your hands up in the air and being like, well, we don't really know, so how are we really going to proceed with making changes? So we have a good timely question in the chat about, okay, so we have this data. That's great. We have that great map. So what can folks that are representative in the audience actually do with this information? How can they act upon it? How can they strengthen their advocacy? Daniel, why don't we start with you?
Sure. Thanks, Chris. Keep in mind that, I mentioned earlier that, payers need encouragement to comply with the law. And the violations that we've seen for the last decade, I wish it wasn't the case, but for the last decade, they've been the same over and over. And I read a few of them at the beginning, earlier. They're the same violations over and over. And in terms of work, and a lot of these are born out of an insufficient workforce and network. And part of that is organizations can use this data to understand, okay, why is there an insufficient network in my area? And contracted rates are a big part of that. So this allows that direct comparison in ways that really has never been able to be done before. And and sometimes we hear, well, providers, physicians, they just don't want to contract with us. Well, if you're getting paid pennies on the dollar compared to medical surgical providers, of course they're not going to want to contract with you. So this injects some elements of again, transparent fairness into the conversation. So, so that's one of the ways that it can be used, and it can be used in ways, and this is in the aggregate. And that's really important because physicians and other healthcare professionals, they can't go comparing contracts and come together and collude and enforce things that way. That is legally suspect. This data is not legally suspect in that manner, and professional organizations can use it to start those conversations. Another way is that this data can also help state departments of insurance. They can be encouraged to take a closer look at certain areas. In every one of those counties, there are state legislators. And so professional organizations, when they know their state legislators in those individual districts, they can say, look, can you help us talk about this with the regulatory agency, with the executive branch of whatever state it happens to be? So it can increase conversation that way, Chris.
Fantastic. Nathaniel, anything to add on that viewpoint, particularly as you think about leveraging this data in the context of creating more competitive and fair marketplaces? You've mentioned antitrust a few times. What are ways of making things more visible to kind of level the playing field for really providers, consumers, state regulators?
And one thing I wanted to sort of bring in is the role of employers and purchasers, because a lot of these plans are ultimately governed by ERISA. So some of these are state plans that are governed by the state regulators, and some of them are large employer-sponsored plans that are governed by the Department of Labor through ERISA. And that gives a major role for employers. And one thing this helps with, to the point of collaboration across stakeholders, is imagine if you're an employer working with a third-party administrator to figure out if you're in parity and reimbursement. And one way of doing that would be to request every single contract with every single provider for every single service. And I just would not want that to be my job at a large employer. That sounds like a nightmare. And so this gives you sort of a way to analyze across all of this data and have conversations around parity that are tractable and feasible. So I think that's another big part of this too, is helping purchasers and third-party administrators be parity compliant. One big thing on the oh yeah, please jump in.
I want to jump in there because Nathaniel, that's a great point, because every employer, when an employee has an issue in their family, let's say a loved one has needs care for a mental illness or substance use disorder, and again, let's say it's an acute condition, but it doesn't even have to be an acute condition, but ongoing continuity of care, and there's disruption in care, that creates a crisis in the family, and that crisis is often felt. It's often felt by the employer. And because the employers, it's a family in many instances, and so we would encourage employers to ask their TPAs, does our plan comply with parity? And what that plan can and should do is provide that employer with an attestation and provide a full parity analysis that they can get under the law. And if the payer can't say, yes, we comply with state parity laws, and then, Houston, we have a problem. So this is an opportunity. If there are any employer groups on the call, or anybody who works in an organization, ask your HR department, does my plan comply with our state parity law? Or if it's an employer, if it's a self-funded plan, does my plan comply with ERISA and the parity laws under federal law? It's a question everybody can go back to their HR department and ask today.
And one thing I wanted to, Chris, to your question, is bring in the antitrust part and competitive markets. And so one huge, profound opportunity, because this just wasn't possible before, if you try, like if in a meeting, two health plans or two provider groups or two insurers, employers tried to share their rates, that would be, immediately illegal. And so being able to see everybody's, rates and networks and everything does create this just like a profound opportunity to sort of equalize and normalize across health insurers and TPAs and employers as well. Because I think one sort of really concrete example was the preventive health benefit. And so, across insurers, if you tried to provide some really expensive preventive health benefit that, had downstream health impacts and cost savings, you would be the one paying for it but then you wouldn't be the one seeing the downstream savings and health impacts. And so there's a huge challenge, right, in financing preventive care. And what federal law did was create a common basis so that every insurer agreed to pay, which would have also been an antitrust violation of all agreeing, agreed to pay for this preventive care so that it sort of grows the pie for everyone. So every, health insurer, there's like average reciprocity. So if one plan pays, another plan sees the benefit, that other plan also paid, and then your plan might see the benefit. And so it solved this huge problem in having a functioning market for health. And similarly, there's a pretty big opportunity for this to solve a similar problem, where if every plan and purchaser has a different methodology for deciding on parity reimbursement and network composition, then there's a big challenge to sort of standardizing it. And once it's set and normalized, then just you can have the opportunity to compete on other basis. And over time, it sort of grows the workforce and has the same flavor of average reciprocity, where as you pay more, then more insurers, like if just a single insurer who has, let's say, 20% market share and a county tries to pay more, that just by itself might not induce providers to join a network because that's a small percentage of the patients they see. But if every insurer had agreed to pay the same amount, then that might actually induce more providers to join networks and more people to go into mental health and substance use care because the rates would just be higher. And so it is a pretty big opportunity to just shift the basis of competition towards better outcomes and quality, and figuring out how to really focus on that aspect instead of trying to analyze payment rates.
Yep. And, that's the goal here, right? Ultimately is timely access to care. That's what's being strived for. And Daniel, you've talked about the real world implications, right? When there are challenges like this that stand in that way. One thing I wanted to just float out to either of you is we did get a clarifying question in the chat, or the submitted questions, about what the clinicians or providers' responsibility is to, and with regards to compliance with parity laws, particularly when they negotiate contracts. To know, Daniel or Nathaniel, if you wanted to, or if you're able to touch a little bit about just clarifying kind of the clinicians, physicians, or other providers' role in that process.
Did you want to start, Daniel, and I'll jump in, or I can start?
Sure, I can start. In this payers have the responsibility to comply with parity. And in the law says, and I'll shorthand here, but that basically a group health plan, and there are other plans, shall ensure that. It doesn't say a healthcare professional. The burden here is on who's providing the promise of benefits to the consumer. And that's the health plan, and that's really important. There's a very clear distinction that, and I think that Nathaniel has alluded to this many times. Two healthcare professionals can't get in the same room and start to compare rates. The health plan knows what they're paying each of those professionals. If they can pay the medical surgical professional up here and the mental health professional here, they'll do it. And which is what they do, which is what the data that you've seen on the screen, that's what that illuminates.
And it would sort of be infeasible for the provider to enforce parity. You could imagine for parity and reimbursement. So Daniel brought up, you just don't know how much your physical health colleagues are getting paid. But you could try to demand parity in your reimbursement rates, but that would, there's sort of no recourse if the insurer doesn't agree to that contract rate. So there's just like a challenge of putting it on providers. Other laws govern providers, like, medical licensing and all those kind of things. But parity is squarely with health insurers, and then providers have a different set of requirements and incentives.
Fantastic.
Yeah, and Chris, I'll bring up another point of that. If it was up to physicians, physicians, and this is something that we, along with the Kennedy Forum and many other advocates, try to pursue at the state and federal levels. We would want providers to use the guidelines from the American Society of Addiction Medicine to govern medical necessity determinations for substance use disorders. We, physicians, would want the guidelines and recommendations of the American Psychiatric Association, the American Academy of Child and Adolescent Psychiatrists, to guide the medical necessity determinations when children and adults are being treated for mental illness. Health plans, that's what we would recommend. On the other hand, health plans fight us tooth and nail at the state level because they would prefer recommendations that are not based on what the most highly trained healthcare professionals support. So we would love it if physicians were required to put the recommendations in about what would constitute the best medical care. By all means, let's do that like yesterday. That's not the case, unfortunately.
So it's great timing, Daniel, because one of the other questions I wanted to flag was just, given all the movement at both the federal and state levels, just shaping this specific space, can you talk a little bit about why state level oversight specifically is expected to be such an important place to ensuring behavioral health coverage moving forward?
Sure. You'll be quick here. The thing about enforcement, and really, but at the state and federal level, this has been a bipartisan issue, or really a nonpartisan issue, for years. And there are, so-called red and blue states that have strong parity laws, where their insurance commissioners have strongly enforced the law. At the federal level, multiple administrations have done a really good job. This has gone beyond what most people see as typical, partisanship, and which is how it should be. Mental illness and substance use disorder is not a political, doesn't abide by political affiliation. And so at the state level, one of the benefits at the state level is that there are real leaders in the states, and I won't name specific states because then other states will get upset that we didn't name them. But some of the states that at the state level have demonstrated how to investigate parity, how to enforce parity, and how to continue to monitor and oversee parity compliance. And we're thankful the National Association of Insurance Commissioners has really strong tools that all states can use. And the Department of Labor at the federal level has really good tools and guidance that they use on an ongoing basis to enforce parity laws. So the tools exist. States need to demonstrate the commitment to use those tools.
Fantastic. So, and we've used the term states, plural, right? We showed data for Illinois, but this is obviously an issue across the nation. So Nathaniel, to you, what are some opportunities and added benefits that could emerge by expanding the index beyond just Illinois at a national level? And how might that broader geographic coverage strengthen transparency, inform policy decisions, and ultimately drive more equitable access to behavioral health care across states?
I mean, we've talked a lot about the benefits and opportunities generally that we've seen in Illinois, and so those would extend to more states that do it. And one really interesting thing that's happened to the point about state leadership is Colorado, for example, made its own version of transparency and coverage. And so we're already starting to see states working to take the lead. But the challenge is the data is profoundly overwhelming. And so standardization and sort of like data engineering improvements are huge. And we're starting to see that with the Department of Labor just put out a proposed rule for transparency and coverage that's designed to sort of address some of these issues, better standardized data, and I think will be really helpful going forward.
Fantastic. So I know we're running up against time. So one kind of last closing question, maybe Daniel starting with you and then Nathaniel having help close this out, but kind of looking ahead, what additional data sources, policy levers, or partnerships could further expand the impact of the index and ultimately, again, improve behavioral health access nationwide?
Thanks, Chris. I think, first of all, the AMA is grateful for the leadership of the Kennedy Forum, for the work of Third Horizon and our other partners to get to this point. there's no shortage of of data, right, that's out there. And so it's really remarkable that we've been able to wrestle this data to a point where it can be shown in a picture and comparisons can be made. And that's a huge leap forward. And so I'm looking, I encourage everybody to use this data, and as if and when as additional states come on board to this, use the data. The other thing to note is that I don't know that we necessarily need more policy. There are some state laws that could be stronger, sure. There's some states that don't have enough policy, that's fine. But every state Department of Insurance has the authority to investigate parity compliance now. The law is there, the policy is there to do it. So it takes commitment. And I think it's incumbent upon the AMA and all of the advocates on the call today to ask for a level of enforcement, commensurate to the need. There are millions of people who don't have ready access to care for a mental illness or substance use disorder, children, adults, seniors. And so the level of commitment that's needed, must be emphasized over and over. And that's ultimately the takeaway. The tools exist. We've just added a new powerful tool. We have to take advantage of them for people to get the care that they need.
And I would just add on that, we've talked a lot about the opportunities to sort of overcome antitrust violations and see real cooperation, but you still need a public convener. Even this data is public, but additional analysis might still run afoul of antitrust violations. And so having a, government convener who can provide liability shields makes this actually cooperation feasible and actionable. We saw this a lot with developing primary care models, where the state would act as a convener in antitrust violations so you could set common rates to enhance primary care. And we definitely need something like that here as well.
Fantastic. Alec, if you want to bring up the slide, I think, I don't know, Daniel and Nathaniel, if you all just want to touch a little bit of just, a few key next steps that our audience members can take coming out of this conversation.
I can start. We've mentioned a lot of opportunities today. Hopefully, one or two stuck with you, and you wrote it down. Sharing your story, at that site is always a great place. I believe our contact information was shared with people. If not, we can certainly do that in a follow-up. Continuing the conversation so that it stays front and center for policymakers is ultimately the takeaway that I'd like to leave people with. And I know the AMA and certainly the Kennedy Forum, we do this on a daily basis. The more people working with us to accomplish the goals for individuals with a mental illness or substance use disorder would be all the better. So thank you.
And thank you, everyone. I mean, I couldn't have said it better. Please do, reach out, share your story with us, and find ways to collaborate. Because, we try to aggregate issues going on all around the country, but for each stakeholder type, there might be blind sites, and everyone's insights are really helpful. So thank you so much.
Well, thank you all. And, more to come. Obviously, there's a lot of work that needs to still happen, but just excited about this opportunity and continue the partnership and the partnership with other folks that are on this call to be able to make a real difference in access across the country. So with that, I will pass it back over to Alec to close us out.
All right. Thank you, folks, so much. We're just at about time. As you have said, thank you to the three of you for your time and expertise today. For all of our wonderful attendees, at the end of this event, you will be presented with a brief survey. I know a small poll just popped up, but there's a couple more questions we'd like to pick your brain on. Please take the time to answer the 2 questions there. Your responses will help guide our upcoming programming to deliver webinars you want to see, such as the one you saw today. And as a reminder, we have provided today's slides and a selection of relevant resources for you to explore, which you can access at any time during the presentation by selecting the resources button You will be able to view this event on demand an hour after this presentation ends using the same link you joined with today. Our next webinar comes 1 month from today on March 17th, where we will champion health workers' well-being and mental health. We'll be joined by Corey Feist of the Dr. Laura Breen Heroes Foundation to uncover how organizations can address the pressing issue of health workers' well-being and mental health. We'll also be joined again by Daniel, so you'll get to see his lovely face one more time. You can register now by selecting the link in the Resources tab. For additional resources and guidance to support your physicians and staff, please visit the American Medical Association website or stepsforward.org. Thank you again so much for joining us, and we hope to see you again soon.